classification of trauma through mechanism of injury. It can either be physical, it can either be chemical, and it can either be a burns with either fire per se or acid burns as well. And the chemical injury which we are most interested in is either acid or lethal. We'll talk about this in slight detail. Another form of the physical trauma can be further classified into high velocity trauma, industrial trauma, accidental road traffic accidents, sports injuries, assault. Assault is the right. The most common form of trauma that we see is majority of it is road traffic accident, and then high velocity, and then assault, then sports, and a very little of industrial trauma, where we work in the part of Karachi that we work in. But all these 5 forms of trauma are included in the physical form of trauma. We'll discuss the primary concept of mechanism of injury. Trauma can also be defined in slightly different manner by the type of injury sustained by any of the above form of trauma. All this in high velocity, industrial, accidental, assault, sports, all this can be sharp injury or blunt injury, and all this may result in, or we can classify the physical trauma by according to the nature of injury sustained by the eye and the legs. So we have blunt injury. The blunt injury can lead to rupture of the globe, or simple blunt injury without rupture of the globe. Surgery per se is also a form of trauma, iatrogenic trauma. And we can have penetrating trauma. Penetrating trauma means something has sharp enough to actually disrupting the integrity of the globe. And we can also have this penetration with intraocular foreign body or without intraocular foreign body. There are 2 words written here, penetration and perforation. What is the difference between them? Penetration means one entry wound, and that's it. Perforation means entry wound and an exit wound, meaning there is a double penetration. So obviously, the obvious consequences that the prognosis for perforation is, for the obvious reasons, would be serious, and the outcome generally poor. Penetration has better outcome, but depending on what vital structures have been damaged. So we'll move forward with now we'll try and understand that. So this is what your primary classification of injury is. It can either be physical or chemical, or it can be burns as well. Now, in burns, if we have lid burns, and there is, you cannot have eye movement, eyelid movements, then it's a very serious condition, and then we have to close the eye so that the the major problem of exposure is reduced. And similarly, chemical injury has its consequences in the sense that it burns, it causes necrosis. And comparatively speaking, acid burns are superficial and of less drastic consequences in the aftermath. But the alkali burn is far more serious and dangerous in the sense that the alkali keep on traversing the tissues and keep on damaging the tissues well inside the eye as well. And it causes ischemia. So we have a primary mechanism of injury in trauma would be physical, chemical, and burns. We'll mostly be talking about physical. In physical injury, we have different forms of injury. It can happen in industrial work. It can happen with high velocity missile injury. It can be assault. It can be RTA. It can be other form of accidents. Children playing with each other, poking things in the eyes, and sports injury. Sports injury, has a big, huge implications because especially shuttlecock of badminton and squash ball is ideal size to actually hit the eye and really cause a lot of damage. Now, the nature of the injury can be blunt or penetrating. Blunt injury can be less, if it's less severe, it will not cause any rupture. Or if it's serious, it can cause rupture. And basically, we also divide the physical injury into either open globe injury or closed globe injury. And when we talk about penetration and perforation, it means penetration is a single entry wound without any exit wound, and perforation means entry wound and exit wounds. So obviously, the perforation will have poorer prognosis. Now, this is the primary concept of injury. Any form of blood injury can be from any source, either a box or a ball, or even concussion injury, bullet passing very near to the globe can also cause this. So what happens is that when we have force applied to the front of the eye shape is changed. And this is called, so if we push the eye this way, so it causes percussion waves and the whole of the eye gets hurt in different manner. Okay. I don't know if we have another, yes, this one. So if you can imagine that the normal eye is from here to here, and with blunt injury, the shape of the globe is changed and it is compressed, and it is this compression which causes a lot of problems, and then when it regains its shape back again, it causes contour tooth injuries as well. So the major brunt of the this change in the shape is taken by the everything: cornea, lupus, ciliary body, vitreous space, posterior vitreous detachment. Can cause a lot of problems. Okay. Next is it. So one needs to really understand this compression business. Yep. As, as long as one can understand when the shape is altered, then that is where we have problem. When the tissue gets disinserted from its place, you can have endothelial breaks, you can have iris disinsertion, you can have lens dislocation, you can have tear, retinal insertion, which is called dialysis, which is a classic example of trauma, retinal dialysis. One can have PVD causing bleeding from the disc margins. You can have huge amount of retinal edema. All this is related to blood pressure. This is an example of a classic anterior subcapsular that cataract secondary to trauma. Okay. This is an example of concussion injury to the retina, whereby the exoplasmic flow is retarded and the ectoplasm gets stuck into the nerve fiber and the nerve fiber layer becomes a vein. That is known as Berlin's edema. It's a misnomer really. Its basic primary thing is that the exoplasmic flow is retarded. It's called commotio retina. It can happen in the center, it can happen in the periphery, and one has to look for it. And people with this form needs to be really anti-inflammatory. And we can have ruptured globe. This is a classic sign of, here you can actually see the globe, nice round, and here you can see the reverse umbrella sign. This is classic, denoting that the integrity of the globe is disrupted. This is penetrating injury into through the cornea. You can take any shape, size. We cater for a lot of trauma and corneal trauma, children playing with each other, poking even with knives, discs, metallic, CDs, cutting each other. This is what happens. And this is a form of corneoscleral tear. This is penetrating, not blunt trauma with rupture. Okay. Whenever we have any injury which crosses the insertion of the horizontal recti, it means that it has entered into this a place where it will have internal incarceration of the vitreous, and that event in itself will cause a lot of problem in the eye. So after primary repair, we have primary repair means that we have to get the integrity of the globe in one order, form the globe, and we have to make sure that before we need to know that either we are dealing with for our body or not. Okay. So whenever we take the patient to the theater and we repair it, and we counsel the patient that it will need secondary repair, because we have to have repair the vitreous, because vitreous, when it gets incarcerated into the bone, it will cause fractional detachment. Okay. So the scenario of vitreous blood traction is, asking for trouble. We have a lot of situations where only the lids gets injured and then the globe is protected. And this is what it looks like. It can happen with anything. It can happen with blood injury, it can happen with sharp things, and missiles and everything. RTA is most commonly happening. RTA is the most common cause of problems. Primary management of any trauma patient is that we have to make sure that they are ABC, airway, breathing, and circulation. Once the patient is stable and we have declared that neurologically they are stable, then the next thing is eye. Okay. So the ophthalmologist comes in after the patient has been stabilized and has been given a clean bill of health from the neurosurgery people. And sometimes we operate with the neurosurgery people, sometimes we will be operating with the plastic people, and sometimes we will be operating with the facial maxillary people. And, the management is combined management. And this is one form of lid trauma. As you can well imagine, if there is, there is no tissue loss, it can be approximated end to end, and it has excellent outcome. And even if we have lost tissue, 1/3 of lid tissue, it can easily be direct approximation will do. And given a choice between the lower lid or the upper lid, so we can sacrifice the lower lid in order to repair the upper lid. And we can repair the lower lid later on. But you just we have to make sure that the upper lid is in good shape, because that is where exposure comes in. Exposure is a real enemy for us when trauma of this kind happens. So if we have a lot of, supposedly, if we have lost tissue and if it's more than half, then we have to release the lid, and then only then it can be end-to-end anastomosis. Okay. This is called a tendral mucocutaneous plan. What we are doing here is actually we make a really huge cut, and then mobilize the whole lid back to here. Now, this was up till here. This is anterior trauma repair. Anterior of the eye is getting anterior portion of the globe injury. Okay. Now we can have injury into the posterior segment. The posterior segment trauma is basically vitreous in the wound, vitreous hemorrhage, infection. Yes. And when the age of the patient is also very, very important. The younger the patient is, the more the prognosis becomes even worse. Because the younger the patient, the amount of inflammation that it will mount will really cause havoc into the eye. all the risk factors that you can well imagine, which is hemorrhage, posteriorly placed wounds, persistent intraocular inflammation, damage to the lens, which causes the lens material itself from within is immunologically not recognized itself. So the body, body immune system mounts a huge amount of inflammatory reaction to the lens protein and infection. And the combination, usually we have the combination of blood, inflammation, and infection. All three. And if it's combined with an intraocular foreign body, then we are really in a difficult situation. So mostly, if the literature tells us that we did try to define PVR with you when we were discussing retinal detachment. PVR is posterior vitreous proliferative vitreous retinopathy, which happens with blood, infection, inflammation in the vitreous, and it causes havoc onto the retina. And it says that 43% of eyes after that, perforation, you have very, difficult situation. And then 11% of eyes develop, got better or good vision after intraocular foreign body, 15% of eyes, sharp penetrating, 21%, 43% after. We can still, salvage something. This is it. This was mostly about penetration. Now the blunt trauma is the only one concept which you need to take regarding blunt trauma is that either it ruptures the globe or it does not rupture the globe, but it will cause problem. Okay. Blunt trauma rupturing the sclera, scleral rupture resulting in it's like implosion. It's not something from within. When you compress the globe, the content are compressed and they will rebound like anything, and it can actually break the sclera. This is an acute injury causing, and especially it can cause a lot of problem in the angle of the eye where you can have bleeding into the vitreous, into the anterior chamber, can cause retinal tears, subluxation, dislocated lens, commotion. We've all talked about all this. Okay. This is very rare. Advanced optic disc has to be serious RTA, which causes this, and with Lee-Fortes type 2 skull base fracture. Scleral rupture resulting in vitreous hemorrhage and inflammation. This is some of the examples. Large lower temporal dialysis. Dialysis is, as we have mentioned, it's a disinsertion of the retina from at the porous retina. It's not indirect. Actually, okay. Disinsertion. We have, vitreous playing havoc with the retina. We've already talked about it. This is the mechanism which causes problem. We have an injury, penetration, and even though when we have repaired it, the vitreous incarcerated here will cause all this. The whole retina is incarcerated there. Okay. This is so we want to go in after primary repair within 2 weeks, so that in this situation where the retina is not detached, and we are preempting that it is going to get detached, so we go in and from inside we clean the whole thing up and leave a stable, stationary situation where there is no traction on the retina, and so safety. We have talked about same. This is what exactly is happening. Just going into the and then gradually it pulls everything towards this entry side. Foreign bodies, the important types of foreign bodies would be the most important foreign body would be iron and copper. These two actually causes chemical injury when they remain in the eye. And the iron and the copper gets incorporated chemically into the retinal cells and causes serious cellular malfunction at the cellular level. And even though it may, you may remove it and the retina may become flat, but still one can sustain, chemical injury through intraocular foreign body. And the two most important metals which happens is iron and copper. So we have to, make sure that the intraocular foreign bodies are removed as soon as practical. One very interesting, actually, thing about intraocular foreign body is that actually, when we had Second World War, people ended up a lot of people ended up with glass pieces in their eye, and that glass piece did not cause any real problems, and that led to the way for intraocular lens. That it gave the idea that if the eye can tolerate something inert in the eye, that means if we do cataract surgery and we can replace it with something which can, correct the aphakia. And that led to intraocular lens development after Second World War. And, this is how we come. One good thing about Second World War was that the ophthalmology got a concept for intraocular lens. And, inert foreign body remaining in the eye, not causing harm to the globe per se or the physiology of it, led to intraocular lens creation. Okay. So basically, the history will make by listening to the history tells you whether the injury has concomitant intraocular foreign body or not. if there is, then investigating it and removing it after primary repair within 2 weeks of primary repair is the key to success. Let's see what else we have. And but as one can imagine that trauma, and especially secondary repair in trauma, is the domain of posterior segment surgeon, is conversant with posterior segment and vitrectomy. And that is how primary repair can be done by anyone, but they need to refer the patient to the posterior segment surgeon as soon as possible, so that the definitive corrective surgery, secondary repair can be performed, and it includes cataract surgery, vitreous cleanup, removal of fractional system, antibiotics, stabilizing the posterior pole with sometimes tamponades like silicone oil. And normally, most of the time, we end up using silicone oil in the sense that they're most usually the trauma sustained is by younger people, and their reaction to inflammation is quite serious. And with one repair surgery, it doesn't end. So we have to continue, monitoring the patient, keep following them up. They need very close follow-up. They will require, they can easily develop secondary glaucoma, and they may need secondary, tertiary surgeries, and it has to be a continuous period where we need to make sure that the eye remains stable. Once it is stable in the first 2 years of post-trauma, then usually we are happy. But if anything bad is going to happen, it will happen within that first year. This is one example of how things can be. You can see this is something entered from here and then exited from here. And this is what one can achieve. Usually, we have to some in these. If there is cataract, we have to remove the cataract before we can actually go in, and we don't leave behind this much of vitreous. This is an old photograph, but this is how that will give you a basic idea as to how to clean up, a double perforation. We leave behind, incarceration. Sometimes we actually remove a large piece of retina from here as well, so that no incarceration is present, and it will not drag the rest of the retina with it. So basically, this posterior segment trauma is the domain of posterior segment surgeon, who's conversant with all the different posterior segment surgeries. And it cannot, not every center has availability of gadgetry which is required for this kind of management. So one has to be careful as to referring the patient to a given person who can actually has the both training and the equipment to deal. So if something, so there was an entry wound here, one has to release all traction, even to the extent of actually removing the retina and then lasering it and putting oil in the eye or gas, whichever one feels will be enough for that situation. This is the incarceration traction. All that. This is also a place where it's incarceration and traction. So we have removed a lot of retina, but it is mandatory. You have to relieve all traction before the rest of the retina can settle. So the primary objective of posterior segment surgery is that we have to remove all traction. Again, this is a giant here, secondary to trauma and incarceration of vitreous and retina. And one can also, if the patient gets to you early enough, and there is no intraretinal shortening, one can actually open this up as well. With fair because the majority of the problems that can hurt the eye is in the posterior segment. So treatment of the posterior segment is the most important aspect of management of trauma, especially penetrating trauma and rupture as well. But penetration or perforation, all these three, penetration, perforation, rupture, all this is the major killer. So we have to treat that accordingly. And now with current gadgetries which is available, the expertise which is available, majority of the time we can salvage the eye. This is a very rare situation actually, where the optic nerve had a burst. This is serious RTA. Sorry, I stuck with a rock during a fall. How do we recognize avulsion? Disc hemorrhages around the disc. This is one of the ways to classify injury as well. Currently, we are most classifying, and for prognostic purposes, we define the trauma with either closed globe injury or open globe. Is it penetration or is it a rupture? If it's penetration, is it penetrating or perforating, or whether there is any foreign body or not? Closed globe, contusion, mostly concussion, and then lamellar laceration can happen. Even with, despite closed globe, one can have endothelial Descemet's rupture. We can have iris disinsertion. We can have dislocation of the lens. We can have choroidal rupture. We can have huge amount of corneal edema. We can have macular hole formation. We can have paralysis. So all this comes in closed globe injury, and this is obviously pure posterior segment. This is our domain. segment people, this can, be addressed by either anti-segment surgeons or segment surgeons with whatever the case may be. And I think this is it. Prognosis has improved with the passage of time. Now, a bit about chemical injury. How do we grade chemical injury? If the prognosis is good, if there is no limbal ischemia, okay. The prognosis is still good if there is only less than 1/3 limbal ischemia, okay. It's guarded if it's more than half, 1/3 to half limbal ischemia. Limbal ischemia means you get complete blanching of all blood vessels around the limbus. Okay, and poor more than 2/3. Okay, and the cornea is usually opaque. It may be cornea opaque, like it will recover for to some extent. This can be recovered. This will. I mean, when we are dealing with chemical injury, we have to make sure that we anti-inflame the eye, we prevent infection, we cover the eye if need be with amniotic membrane. We can close the lids for the cornea to recover or heal. Because once we are here,